the calibre trial is, calibre stands for carvedilol versus variceal band ligation in the prevention of bleeding in patients with liver cirrhosis. So this is a NIHR funded randomized control trial, and so it is going to be rolled out nationally. And some may remember the trial in patients with alcoholic hepatitis called the Stoker trial. So this is also an NIHR funded trial. So we're actually going to be approaching all the centres that recruited for the Stoker trial. There were over 66 centres in total, and we're at the stage of setup. So this means doing the protocol, all the regulatory bits and pieces like trial registration, MHRA, and approaching all the pilot centres. So we have a 12-month pilot. So we approached 20 centres for a 12-month pilot. So over the next 6 months, well, probably a bit less than 6 months, we're hoping that the setup process will be complete and that we will be ready to recruit. Obviously, when we start depends on approval of the different sites, R&D and contracts. So this is, calibre is an NIHR funded trial, as I've already said, and it came about really due to a need for a large trial to investigate patients who have medium to large viruses that have not bled. In the United Kingdom at the present time, there is a disparity between national guidelines. So on the one hand, NICE have said to do this. On the other hand, the British Society of Gastroenterology have said to do something similar but not quite the same. So there is a bit of a disparity, and the resource implications for band ligation are enormous. It is an expensive procedure. It requires patients to come in not just for one, but for 4 to 5 endoscopies to have the procedure. Whereas the carvedilol is shown to be very effective, better than other beta blockers in portal hypertension, but it hasn't really been studied in a large trial. So the primary endpoint is variceal bleeding, and there are a number of secondary endpoints, which include obviously survival, mortality, and also beta blockers. There is a lot of interest in the role in advanced liver disease and whether they can reduce decompensation. So liver decompensation is one of the secondary endpoints include, and also other complications of cirrhosis like liver cancer, infections. There's also a qualitative element of this. We want to see, for example, particularly in the pilot, patients that have not consented for the trial, why they've not consented. There's also health economics, so there's a cost-effective analysis as well. So the trial is powered to show that carvedilol is better, which is why the sample size is so large at over 2,500. And if the trial shows, and this is into the future, we're talking recruitment 4 years and 1 year follow-up, so it's 5 to 6 year length in total. If the trial shows improved survival, less bleeding, improved survival is fantastic, but it's not powered to show that. If it shows less bleeding with carvedilol, the carvedilol is going to replace band ligation as primary therapy. And this would have enormous resource implications. Obviously, you have less bleeding, less need for endoscopy, because once you put somebody on a carvedilol, you do not need to do any further endoscopies. Whereas if somebody's having banding, they need repeated endoscopies indefinitely. So you can work out the maths there. Procedure that costs hundreds of pounds versus a tablet which costs less than £1 a month. So there's huge resource implications to the NHS if the primary endpoint is in favour of carvedilol. In total, there are the estimates from the NICE are there are around 60,000 patients with liver cirrhosis in England. That may be a slight underestimate, but that is at any one time sort of prevalence. And half of those patients will develop varices. So it's a lot of patients, and so 30,000 will develop varices, and maybe about 10% of those will develop varices that can bleed. The overall prevalence of cirrhosis is probably slightly on the rise, and so the problem of variceal bleeding is going to be an increasing problem. There'll be steady rises in prevalence of cirrhosis. So I think it is a very relevant and very important problem to address. It's one of the most dramatic complications of liver cirrhosis. If somebody presents with a variceal bleed, it is a major life-threatening emergency. So the program's fantastic, and I, as we discussed earlier, I particularly enjoy using the app. It really helps to plan the entire conference. It's a long conference, and there's so much that you need to focus, otherwise you won't make the most out of it. So I actually downloaded the app in advance and planned ahead, and I have particular interest in portal hypertension actually, and also I have interest in vascular liver diseases. So there's a special interest group in EJournal called VALDIG, Vascular Liver Disease Interest Group, which the chair is Juan Carlos Garcia Pagan. It was founded by Juan Carlos and also Dominic Pala, and I'm a member of that group. So they had a session early yesterday morning, and also early Wednesday morning, and also had their general assembly late on Wednesday as well. So I went to those sessions. But in terms of what I'm looking forward to some of the interesting parallel sessions on portal hypertension. I have particular interest in clinical aspects. There's also sessions on Meet the Experts. I'm hoping to go to one on portal vein thrombosis today. Although I believe there's a lot of, the rooms are quite small, so you need to get there well in advance so you can get a seat. And there's also a session where they're looking at the literature as well. So they dissect out, these are landmark papers in 2017, so I'm hoping to attend one today. And there's sessions on portal hypertension clinical aspects, and also this very interesting session on intensive care in patients with liver disease. Very much so. So obviously I've talked a lot about the sessions, but you have lunch breaks and you have coffee breaks. So it is these breaks, and at any time in the conference there's ample opportunities to meet other colleagues and to network. And that is so important. This is something, people say, oh, you don't need to go to a conference, you can just look at it all online, and you can. I mean, everything is recorded, and you can log on if you're an EJournal member and access a lot of the talks, but it's not the same as being there and actually interacting with colleagues. You need to attend the meetings and interact, because there are things that, when you talk to somebody, it's so different. So we have shared research ideas, and the VALDIG group that I mentioned just earlier, they are proposing a number of studies, and I am collaborating. And I wouldn't have had that opportunity if I hadn't attended ILC. So you can't get that just by email. So you actually need to be there in person and attend the meetings and the committee meetings. And this is really over the years, many years that I've attended these conferences. That's why I make a point to really attend, and so that I can interact, share ideas with colleagues and collaborate. Very important aspect of these conferences.
It's actually very important for you to create research collaborations over the years.
Very much so, very much so. I'm a member of the UK Portal Hypertension research group, so we had a kind of informal meeting, so some of the members got together and discussed clinical trials in portal hypertension just yesterday. I started at the Queen Elizabeth Hospital about 10 years ago as a consultant hepatologist and liver transplant physician. So at that time we were doing 140 transplants a year, and in the last financial year we were doing, I haven't got the exact figures, but I know that we were above 200. So in the 10 years, we've increased the number of transplants from 140 to 200. So just to give you an idea of increasing burden of liver disease. Maybe the numbers haven't shot up, but there is an increasing burden in terms of the severity of liver disease. So we're seeing more and more severe liver disease, and you can see that in the growth of our clinics. It's almost like a 10% growth every year of clinic activity, and because there have been so many advances in the last 10 years, and the unit is so research active, we are actually attracting patients from outside the region. And there's also a national rare diseases initiative, a government initiative to improve care of these patients. So Birmingham has, I think, the only national rare diseases centre for adults. So I have a clinic there for vascular liver disorders. So I'm seeing more and more patients with particular liver diseases, and also my colleagues are attracting more patients as well, because some of them, a lot of us are involved in clinical trials. So at the moment we still have a little bit to go in terms of improving access to transplantation throughout the country. I think things are a little bit better. I mean, I know that in the past, the areas that needed, where there were patients that required transplants most, had worst access to transplantation. But there have been some measures to improve access. For example, I run an outreach clinic in Liverpool. So patients there, I see patients in that area, they don't need to come all the way to Birmingham, and we can start the kind of the transplant assessment process there and then. And I'm one of many colleagues in liver transplant centres who do this kind of outreach work. So that has really grown over the last few years, and it's so important, because I don't think the number of liver transplant centres is going to increase, but we are reaching out to areas where there may not be optimal access to transplantation. You may be aware that there have been two recent publications, one by the government, the NHS Atlas of Variation, published just last year. This was the second one, and the first one was published in 2013. This showed quite marked disparity in, so if we look at one of the metrics, which was years of life lost to patients less than 75, liver disease comes fourth in male patients and second in female patients. And in some parts of the country, the mortality rate is almost 8 times higher than in other parts. And some patients die 9 years earlier in some parts of the country than other parts. So there is quite a disparity, and particularly as liver disease is largely preventable. And the main areas are alcohol, viral hepatitis, and also fatty liver disease. So there are a number of initiatives to try and reduce the burden of alcoholic liver disease, and there have been some successful initiatives in the Merseyside area. And also there is something called it used to be called Liver Quest, now it's called IQLS. This is national accreditation. So liver units need to be accredited. So there's a number of quality standards. So this is being rolled out nationally now, so that if you want to be badged liver unit, you need to actually be accredited. So there's a number of quality markers. And also there's increased public health initiatives. You've probably heard about minimum unit pricing. This is now active north of the border in Scotland. There's a lot of lobbying to try and introduce something similar in England. And also, most of us have heard of the sugar tax. It's up to the manufacturers, it's not being enforced, but it's going some way towards reducing the burden. And the burden is huge. We're talking billions of pounds of taxpayer revenue lost because of loss of days working for these patients that have morbidity from liver cirrhosis. When I was a trainee, junior trainee all those years ago, I won't say exactly what year because that'll show my age, so I was interested in gastroenterology, so I liked the procedures, I liked doing endoscopy, and then one of the consultants introduced me to hepatology, and he had strong links with the Edinburgh Liver Unit and the Liver Transplant Unit, so I was appointed there as a specialist registrar, and then I looked into research opportunities, and I got really interested in portal hypertension, because I liked endoscopy and varices, so I got really interested in that. And Peter Hayes, Professor Hayes, and a lot of people are aware of, he's Professor of Hepatology in Edinburgh. He really inspired my interest, and he supported my research. He was my supervisor for my research in portal hypertension, and achieved a higher degree, and it's really stemmed from there, because he was so enthusiastic, and he kept everybody interested in the topic, and he was very, very supportive. So that was really how it started. Complications of cirrhosis. So we're talking variceal bleeding. There's a lot of interest in transjugular intrahepatic portosystemic shunts, or TIPS. There's interest in early TIPS. This is early on after a variceal bleed, to try and reduce the risk of bleeding and death. A trial published a number of years ago showed dramatically improved outcomes in patients who underwent the TIPS rather than normal standard of care. Real life data is a bit variable, and I know that there is a trial which is about to finish recruitment in Scotland on early TIPS. I think we need more data on that, particularly patients who have gastric varices. There's a lack of studies. Problem with all of these studies is very difficult to recruit. There are not many patients, and some patients are not eligible, so really difficult in recruiting. There's also interest in ascites, if you look at that. So not just, there's now an interest in TIPS for ascites, not end stage, but actually getting there early when you have to keep coming back for repeated drains for ascites. So getting there early. It is about early and prevention because once you get to a certain point and you develop a number of complications in liver cirrhosis, the only option then is a liver transplant. We want interventions well before then, before we get to that stage. So you need to stratify patients. So stratification is important. So some patients with early stage liver disease treated differently from those with more advanced liver disease. So we just need a bit more insights into that and more studies looking into that. It is now, and I keep going back to the app, it is now so easy we usually get, I think, access to the app about 2 or 3 weeks before the conference, and you really can see all the full program, and now you can download even the posters, electronic posters, so you can see almost the full program, and you can even communicate with the poster presenters through the app. So really plan ahead, and also if you're having any meetings as well, plan that well in advance, because it is such an opportunity to network. As I've said, it is more than just going to these presentations, it is about networking. So plan that well in advance so that you make the most of that time, because the collection, the IQ must be through the roof. We've got the top people in hepatology here, and we need to make the most of it. So if you have questions to ask, think about that beforehand. Yeah, it's all about preparation. So I particularly enjoy it didn't used to be called ILC, it used to be called the EASL annual meeting. So a lot of landmark studies have been presented here, and related to portal hypertension, related to viral hepatitis, cholestasis. There are a number here I just went to the plenary on viral hepatitis and cholestatic diseases. So there's an opportunity to see these studies, interact with the presenters as well, and their networks. If I didn't attend these conferences, I wouldn't have been aware of this VALDA group so much and interacted with individuals. So it is about the interactive component that is so important, and nowadays current generation are thinking, social networking, it's not the same as face-to-face, it's very, very different. So I'm of a generation before the internet. So you do actually need to speak to somebody, not just text. Yeah, so obviously with calibre, that's taking up a lot of my time, and there is a lot of interest in prevention of vascular bleeding by the NIHR, NHS, because it's such a huge resource, so resource hungry. Somebody has a vascular bleed, they end up in intensive care for days, and each day in intensive care costs, it's very, very expensive, and the mortality from a vascular bleed is up to 20%. So 1 in 5 will not survive. So really, there's a lot of interest in that. So it's prevention of vascular bleed, and also starting early on in the process. Even at the slightest hint of a varices, you should start treatment. We don't know that at the moment. We don't know when is the best, how early to start treatment in patients with varices. So I've also applied for a grant for another study to look at that, early varices. So the theme is get there early, because by the time they require transplant, you kind of miss the boat. So it is about getting early and stratification. Also collaborations with the Vascular Liver Disease Network, so we're planning a number of studies in this very, very niche topic. So we're talking small numbers of patients, and the only way you can study this group of patients is with the international collaborations.
Thank you very much.